Good afternoon, everyone. This is Kate Stenyam. I'm the program manager with the SHIP program at the National Rural Health Resource Center. I want to welcome you all today to the SHIP Learning Collaborative. This is part 2 of improving quality reporting in provider-based rural health clinics. We're thrilled today to have Sarah Craig, the Director of Health System Innovation, South Carolina Office of Rural Health, and Dr. Greg Barabel, the Physician Advisor at the South Carolina Office of Rural Health, join us for this second session. I do want to go over something real quickly before I turn it over to Sineva for some housekeeping rules. The SHIP, as you all know, SHIP TA is available as you guys are working on your grants. We've had lots of TA questions, but just wanted to send a reminder that if you would like to have your state's work plan and or the project narrative reviewed by our team, please have that sent over to us by Wednesday, November 28th. Again, for your grants this year, if you'd like to have your work plan and or your project narrative reviewed by us before you submit it, you can turn that over to us by Wednesday, November 28th, and we will review that and return it with any comments to you by Wednesday, December 12th. So I will send out an email about that as well. And just as a reminder, if everybody could mute their line, that would be great. Now I'll turn it over to Sineva for some housekeeping.
Hi everyone, my name is Sineva Hackman. I'm the new program coordinator for SHIP Technical Assistance Team with the National Rural Health Resource Center, your TA provider for SHIP. We're glad you could take the time to be here with us today. So before we get started, I'm just going to go over, like Kate said, a few housekeeping details. When you call in, your phone line will be muted. To unmute or remute your individual line, press *2. And once you call in, please keep your computer speakers on mute to avoid any echo or feedback. You can communicate via the chat box at any time, which is located on the left-hand side of the screen. We will go over any questions at the end of the presentation. The file share box located in the lower left corner of the webinar screen also contains a copy of today's webinar slides. When you click on the name of the file, in the file share box, you can then click on the download button to download that file directly to your computer. These materials will also be available on the SHIP TA website. As we've already started the recording for this webinar, I'd like to turn it over to Kate Stenyam at the National Rural Health Resource Center to get us started. Kate, you're welcome to go over the agenda for today's call with the brief speaker introductions.
Yeah, so the agenda for today's call is doing quality improvement overview, the quality improvement metrics, and the quality improvement methodology, as well as discussion. We'd love to hear from all of you, and I know Dr. Barabel and Sarah Craig would as well. So if you have questions, just *2 to unmute your line, or you can put them in the chat box, as Sineva had mentioned earlier. And with that, I'm going to turn things over to Sarah and Dr. Barabel to get started. Yeah, go ahead. Before we get started, actually, I'm sorry, we do have a quick poll question for you to fill out. So if you could, those of you that have already signed into Adobe, if you could fill out this poll question for us, that would be great. I feel confident in my knowledge related to quality reporting in provider-based rural health clinics. You strongly agree, you're neutral, you disagree, or you strongly disagree. We'll leave that up there just for a minute before we go ahead and get things started. Okay, thank you. And some of us just going to move that over to the side for those of you who have not filled out the poll question yet. And with that, we will turn it over to Sarah and Dr. Barabel.
Hi, everybody. This is Greg Barabel. I'm a pediatrician, certified coder, and a physician advisor to the South Carolina Office of Rural Health, and I'm really excited to be here talking with you all today. I see from the survey results, people are a little bit on the neutral to kind of disagree or strongly disagree side. I'm not sure if that's with the quality improvement or quality reporting overall, or just specific to this grant. If you want to be shooting questions, or even just right now at the beginning in terms of what you kind of want to get from the webinar over on the chat box, certainly is can help me to kind of guide where I'm going to go with the narrative for what we're going to say. And so so with that, we'll kind of jump right into this second part of the webinar series, talking about a quality improvement overview, just in terms of the way that I view quality improvement from working with hospital systems in the Medicaid managed care industry and with the rural health clinics. Briefly touch on quality improvement metrics, come back to that at the end, and then talk about some different levels of quality improvement methodology, but really focusing in on what I believe is what can be used on boots on the ground to help bring in and coordinate the various groups of people, hospitals, administrators that you need to bring in order to accomplish the goals that you all are going to set for your SHIP grant. So really, in terms of an overview and how I always look at quality in the healthcare system, is the Institute of Healthcare Improvement's triple aim: improving the experience of care, which is really the patient level, the health of the population, the system level, and the per capita cost. And the Institute of Healthcare Improvement believes that the new designs that we come up with have to be developed to simultaneously pursue these three components. And really, I think is when you guys are thinking about your programs that you're submitting and going to do, kind of the ways of thinking about how it fits into the value proposition. So value being, in the case of thinking about that triple aim, the quality and service as the numerators, so your experience in care and the health of the population as your numerators, and the per capita cost as your denominator. And so from a value perspective, overall, costs can rise as long as quality and service rise to a greater degree for that value to increase. And that's kind of the difference between cost savings and and an incremental cost benefit of a service. And it really, I think, it depends on where you are within an organization that in terms of what you put the value on. So certainly an individual patient can put the value on the quality of their own care, the community at the service, and possibly the hospital administrator on that cost. But also, even in terms of a rising cost, it can be looked on positively if you're the receiver of that revenue, if you're the provider who's now able to bill for a new service, or the one who's receiving a new type of equipment versus the bearer of the expense for that increased value. And this kind of equation is really why I believe there's such a struggle within quality improvement in healthcare. It's not a simple equation like this, and again, value can hold different meanings and have different weights to each individual in the system. And that's really why I believe that we have these 5 stages of grief in quality reporting. And this is a concept that is not my own, is not unique. Dr. Joseph Peritito gave this talk in 2016 for an NCQA conference. And he took it from someone before him, and she took it someone from before her. So this is kind of the long history of R&D, which in quality improvement we consider R&D to be rip off and duplicate. As I mentioned a little bit later, using tried and tested methods, learning from other people's mistakes, and building off others' work is a hallmark of rapid quality improvement that you should never be afraid to utilize. And Sarah and I had mentioned it before, and certainly mentioned again that we're here as resources to bounce ideas off of, or really to help you along the way as you're doing your applications, and also as the year goes on and working on quality improvement, just to be able to talk and discuss about some of the things that you're seeing and expected and unexpected results that you get. And I don't necessarily think that, for the SHIP grant, you're going to encounter necessarily these stages in their protracted components, but definitely is good framework to understand helping how to herd people and to herd the resources in the direction towards better quality. So the first stage of grief being denial, and that is pretty much always, your data is wrong. You sent me a list of 1,000 patients that you said I didn't do something. I found one where I did. I'm not taking a look at this. Or, in the case of for what you all are doing, this is an improvement that I don't care about. I don't have time to care about this. This is a concern that shouldn't exist, and I'm not really going to give or pay any attention to to what you're doing. And and I think that it's a valid emotion that people feel. And certainly, being the start is, I think this is the point where you try and find the value that individual or provider office has in partnering in the change that you are proposing. Getting down to, well, if this is something where we've been given money to do this as an improvement, but really, why is it going to be an improvement for them or for their patients and really for what they value? And welcome, thank you, Louisiana, Alabama, and Tennessee. No problem. So anger, no anger there, but anger. I'm calling the C-suite and I'm emailing every listener that I can find to tell everyone that what you're trying to do is a waste of time. You have bad data, you have bad plans. I'm talking to everyone in the organization and I'm bringing it to the Thanksgiving dinner table. And sometimes, a lot of times, the people are right. Again, kind of getting back to the where someone's values lie, and when you're bringing the information in terms of movement towards quality improvement, that report, just like the system, is not going to be perfect. And this is the part that, as the organizers and the leads of quality improvement, that we have to work through this component, because better data does mean better measurement, and there's always components that are right, and improvement is always achievable. I always like to say it's quality improvement, not quality perfection, because trying to strive for perfection is something that's going to be sometimes unreachable. It really does get harder and harder to get past that last inch. So it's a part where when people come with the anger, you need to recognize it and to confront it with with the information that you have, and talk through why they believe it's not valid, why they think in your case that it's not a worthwhile investment, to be able to partner and really find a way to move forward. So next is marketing. And this component, you'll see a lot. I think if you're going to be working in the value-based performance metrics, where you're looking at system changes and and evaluating performance of the physicians, the nurses, in terms of the level of work that's defined as quality that they're doing. A lot of times when I was working in the Medicaid MCO, I'd hear, my patients are sicker. That's why I don't do well on this metric. Thinking again about some of the value-based metrics, that that could be a reason my readmissions are higher, my spending per beneficiary is higher. And honestly, I do think there's some truth behind this in the rural areas. But whenever there's a notion that someone's patients are sicker, their system is needier, I think that's when it's important to really dig in and look where there's variation, to be able to show how to move to the next step. Starting at the higher system level, identifying where variations exist in terms of the processes that you're measuring or the outcomes that you're measuring, and being able to kind of bring it down to the provider office level, and and hopefully someday to the doctor level, to show how while someone's patients may be sicker than others, there's still variation that's controllable. There's still operational changes that could be made without having to focus on the quality of care that someone's providing, to be able to show how change can be an improvement. Luckily, in the case for the grant, if you'll be starting with, we have this money to do this, and it's not a forced upon change necessarily. But again, as I'll talk about later, it's something to think about in terms of your planning for what initiatives and what roads you're going to go down to understand who's going to be affected and who's actually going to need to make that change. So after bargaining comes depression. And this is the point where I think it's where the decisions are made, based on the tools, the resources, and the amount of time and money that's afforded to the system. What can you actually do? How can you set your goals so they aren't so far off that they're going to be, unachievable? Like trying to get through a winter in New York without snow. I mean, that's just not going to happen. And this is where the use of the continuous visible quality improvement metrics we're going to talk about help to show that change is possible, achievable, and that it's happening in these small incremental steps. And when you get through that piece, you get to that breakthrough, that aha moment where people buy into the change needs to be made, and a change can be made, and that the increase in value is something that they value, not just that the system values or they're being told to value. Some of you may be avid runners and know that rush of endorphins when you hit mile 8 in the marathon, and that's kind of my rush. This is when I know that rapid cycle change is about to occur. But really, just like the marathon runners, you're going to get tired again at mile 20. And so we need to have a training regimen to ensure that we keep going. So kind of what's the cure, what's the answer? Of course, it's the title really of the presentation. It's continuous quality improvement. That formal approach to analysis of performance and systematic efforts to improve it. And really this is the take-home message, is putting a method to the madness, which is really important. And what I'm here to do is try and give you a recipe, a pathway, to do better, see it on paper, and also help people see it in practice. Within quality improvement, the concept of just do better is over. You have to help to model behavior, model the systems to put in place that support the right thing and make the right thing to do the easier thing to do. So in the last presentation, we had talked about the quality improvement metrics that CMS has this vast array of different components. So just wanted to kind of touch on that again, but we're going to go back to this at the end of the presentation where we talk specifically about the different pieces on the menu that you can choose from. And as I'm going through the kind of quality improvement methodology, if anyone has an idea or a specific topic that they already know that they're going to be doing for the grant, please throw it into the chat box, and I can help to can try and kind of incorporate that in and get you guys some free help along the way. So there's various quality improvement models and frameworks and methodologies to choose from when structuring your change paradigm. And what I'm going to do is I'm going to kind of go through a few from a larger systems perspective down to the boots on the ground framework that I think is really important when you're the one who's leading change and having to herd people towards a final goal. And a lot of this information that I'm including in here was taken from the SHIP website and the Rural Health resources. And if you look on the bottom, these are hyperlinks where you can go and get to the document that has more information about this component. So the Baldrige Framework is something that takes an overall systems view of the different pieces that are going to be involved in quality improvement, and the components that you can look at as separate buckets to all come together for a system that can perform meaningful change and work towards the performance excellence. And the most important part in this framework, what they found in the research, is the leadership. It has the strongest relationship to organizational outcomes and value, and more than twice the effect of any of the other components in the blueprint. Excellent rural hospitals invariably have excellent leadership. And so for you all, as you're thinking about your grant and the changes that you want to make, what is the leadership internally in your system that you may need to help push things forward when needed or move the needle? And for the provider-based RHCs, who is the leadership there, and even do they have the authority to be the leader, or do they just have the responsibility to care for the patient? So, as you're looking at making changes for the provider-based RHCs, understanding who is the change decider is a very important part. As we talked about again at on the last webinar, the strategic planning, and in that piece, I really mean strategic planning in terms of what is already being done within that hospital system, both with and outside of the provider-based RHCs. Patients, partners, and communities is something that a focus on the building relationships is extremely important. And certainly measurement and feedback is the piece that I'm going to get into in just a bit, as what I believe would be your role, or the role that you would help to develop an institute to make sure that you get the outcomes that these dollars are going to go to support. So one of the resources I found very interesting, and again, the hyperlink is on the bottom that can bring you to the full document, with this hospital transition to value strategy map that really points out and kind of takes the Baldrige Framework and puts it in a more serial series of interconnectedness, and gives different components to be able to look at. And so I think you have the sections on the left, and then within the boxes the questions on the far right. It's going to be something to kind of review to help to frame how the anticipated use of your money will serve the different components of the system. From a financial perspective, learning and growth within the system, the change of internal processes, and again, coming back to a focus on the patients, the partners, and the community. In my mind, we're fostering improvement in the healthcare system for our patients, for our partners and communities, and garnering the information from them and telling the story back to them should really be kind of at the forefront of your mind as you're doing your planning on what you're going to propose to do for this grant and for the dollars. And they do have a good grid that you can use to be able to have a basis and a structure for your quality improvement efforts. A lot of times that's one of the components that I think people feel more uncomfortable about is how do you track the quality improvement in a meaningful way. And report cards, scorecards are always great. And I like this layout, but I think the piece that it lacks when you're looking at the sections of the who, what, when, why, and how is there's no component here where it's showing who are the people who are responsible to change and who is going to be measured. And again, that goes back to, do they have the time, the resources, the knowledge, and especially the authority to make those changes that are necessary. And so that's where you get to the kind of feel like the ground level and the methodology that I use most often when working with practices and systems, is Plan, Do, Study, Act. And this is the framework of what you would continuously do when when a program is started. But before you get to that point, there's three important questions, three powerful questions really, that have to be asked so that there is a clear focus and understanding of what you are working towards. And those are the three questions are, what are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result? What changes can we make that will result in that improvement? And so it kind of breaks down into aims, measures, and ideas. So when you're looking at aims, looking at actionable and useful aims and kind of think about how to bring that aim into focus is the place to start. And I really do believe that, these are questions that kind of should be answered and looked at prior to or as you're going through your grant development process, because this really will help in the long run to help understand the system. What are the different changes that are going to be made to get to that final goal? So the team needs to set clear and focused goals with measurable targets. And the goal is to require the clinical leadership and focus on problems that cause concern and things, in my mind, that are to the betterment of the patients and the staff. And so, it's not just we're trying to increase patient experiences of care as a value-based purchase activity, but we look specifically at different components. How long is each patient waiting at each step in the timeline of check-in to check-out? And some components, how happy are they with their, with the care that they received, which, as I talked about before, is can be a sticky question because the assumption that you should leave with something in hand, say someone comes in with a cold, they want an antibiotic. If they don't leave with that antibiotic, even though it may not be indicated, they're going to consider that to be less than optimal care because someone didn't get what they wanted to receive. And this is an example, but I don't know the patients, I don't know the system, so I think getting frontline input in terms of what changes does the system want to make is key. And knowing how you can measure it, not if, but how you can measure it is important, because knowing how you can measure it could be of the utmost value as you go through and make your change cycles and make your plans of getting towards that final goal. So the next piece, the next question you have to ask is how we know that a change is an improvement. And taking a look at measures, obviously as indicators of change. And really everything can be measured, but the questions to ask with your measure it, can it be directly linked to the overall aim and goal of the system? Is it a useful change and to who or whom? Not to slate on here, but something that I always think about is what are the balancing measures or other system components that are going to change either positively or negatively when you're putting something else into a workflow or a system. And again, that's why it's important that it's integrated into the daily workflow, because by having an understanding of what the process is like, it helps to identify where the components within the system that will be more easily changed. And there are tons of places to be able to get information from the hospitals and provider-based systems themselves, their EMRs, their practice management systems, billing systems, and patient feedback. But also, if you want to look at kind of at the community level and burden of illness or changes that need to be made using national data sources. And all of these, again, are hyperlinks that you can go to find information. And I pull these all off of the Rural Health websites and different components that have been used before to help with system change. The Blue Cross Blue Shield Health Index was really interesting because it goes down to a very granular level, community level, to show what diseases and conditions are most impacting the quality of life for the people within that specific community. And so, it's something you can go on and look at where you live, your parents live, brothers, sisters, friends, and see and compare to see what is the burden of illness that's most affecting people. Again, it may not be your primary goal to affect change or say to change the level of hypertension, but if you're looking at computerized ordering, pharmacy ordering, or implementing ICD-10 training, knowing that hypertension is one of the highest prevalent morbidities within the community can help to focus and help people understand how this change of putting in computerized pharmacy ordering or doing training on proper ICD-10 coding is going to help the system overall to better improve. And some of the other pieces on here, the Health System Data Center provides access to the Commonwealth Fund's scorecard on state health system performance. The National Ambulatory Medical Care Survey gives information on the care services, including those that are provided by office-based physicians versus the hospital emergency outpatient departments and surgery centers. So again, understanding where the care is happening within your system can help to understand where or how different components will map in as you're making your change. And then again, the last question being, what changes can we make that could result in the improvement? And so thinking about the perceived process, what do they think is happening, the reality of it, what's really happening, and what's the ideal process. And you're going to be submitting a grant to make a change within the system to try and get to an ideal process. So what does that ideal process look like, and how is it working in reality, and how are people actually perceiving that it's working? Or, because if they think that everything is working great, no changes need to be made, you're starting all the way back at that, at denial. And so some improvement strategies more on a provider-based RHC level, eliminating the waste, improving workflow, helping to manage that variation, all pieces where, this can kind of help get the brain juices flowing on what to think about in terms of how is your change and what you're applying for, how is it going to make a difference in the system? Really what changes are going to be made that are going to result in an improvement. And then kind of coming back to the measures, selecting ideas that directly link to the aim, they're likely to make an impact. And, thinking forward, how you can look at those as a series of tests of change, things that could be done in rapid cycle. Again, you're going to have your end goal, but working towards that in small rapid cycle changes. And what's the smallest group that you can get together to start those changes and really get the ball rolling. So what you're going to end up having is this kind of run and repeat cycle. Small scale tests, into fine tuning, and then looking at a wider scale test of change, and then implementation across the system. So some key points, again, always documenting the questions you want to address and making your prediction prior to this PDSA cycle. I mean, your prediction at the end is going to be, I'm going to do, and we're going to accomplish what we set out to do in the grant. But again, making the predictions on the changes that need to be made so that it is a fully and successful implementation. Again, those smaller tests, and really relying on failed tests. Failure is a great thing. It really gives the necessary ingredients for that recipe for success. And I think it's something that we continue to strive and work on. So looking at where the changes that were made, were they conducted well? What modifications need to be made in the setting of the changes, and is what you're measuring sufficient to detect improvement towards your goal? And so we kind of come back to, again, the plan, do, study, act cycle, and kind of pulling it all together for what you do at each phase, and really documenting, this is what we're planning to do. okay, we implemented this on this day with 8 patients or 5 doctors or 1 system. Studying what the results were, and then again acting on it to go in that cycle and move again. So getting into the the specific strategies or components of the that are on the menu. I know that the HCAHPS data collection process is a funding priority. And again, kind of points back to provider communications, patient and family engagement, and things that directly impact that patient satisfaction. So whether it's getting a new vendor to help you to implement the better quality reporting, or looking at the reports and seeing where you can make an improvement, I think those are all great and valid activities. And we talked a little bit about kind of the efficiency of quality improvement training. So even implementing a course that is teaching people Six Sigma or Lean or the Plan, Do, Study, Act cycles. Looking at things that are kind of inherent in the healthcare system, like reducing readmissions or reducing infections, reducing that inappropriate antibiotic use. And I think the provider-based clinical quality measures training is where you would really see those 5 stages of grief when the docs are having to be measured and compared to one another. And that's really where you get the most kickback. But it also could be something where it would be of greatest benefit to them, because in our systems today, I know almost all state Medicaids have a withhold or incentive programs that they use with their managed care organizations and with the providers. So teaching the providers how quality is measured can help to bring dollars back into the system and may be able to help their bottom line. So while the hardest to do, also could be something that could be the most fruitful, and they could understand and see how it could personally bring them more value by bringing in dollars and increasing their quality. And so, in terms of ACO or shared savings investments, I think these are more focused on operational components of the system. Even though to me, the Accountable Care Organization or shared savings really inherently looks at these components of the value-based purchasing. So again, we talked about the computerized ordering, training for pharmacy services, disease registries that even help you to know what are you looking at within your community. And within the documents that have been provided by the SHIP staff, there's a lot of great information that you can dig into to see how these components may work within your system. And of course, have to mention community paramedicine training, which is something that Sarah has been helping to develop within South Carolina. We've been seeing some amazing results. And again, if anyone wants to know more about that piece or has any experience with it within your communities, we would absolutely love to hear about it. And then again, going into payment bundling, prospective payment systems, things that are pretty much directly related to tracking the system through coding. So we had talked last time about ICD-10 training that South Carolina had done and had given a link out to some resources there. And then those cost reporting pieces that are specific to the hospital, I think, are places that you could look. And again, this is something where you could pick one from each A, B, and C from the menu, everything equaling up to that $9,000 to be able to work and help to improve your system. But I do think that this is something that, again, the transparency in what you're doing and visibility throughout that change is happening. You know, don't just say we're going to put in place an ICD-10 software and then come back a year later and say that we did it. You know, really think about how are you going to show the value to all the different pieces in the system, that the improvements being made, the money was put to good use, and that people are informed and can also contribute back in to help with the process as it goes along. And so with that, kind of reached the end of the presentation. You know, we have both Sarah and my email addresses here. I very much encourage anyone to reach out, you know, ask questions, tap in. You know, we're here as a resource for you, and we're free. And it's something that we would love to help, you know, all the rural health providers in the different states to become stronger altogether, because that's our goal in South Carolina, and we really would love to share that out with the rest of the U.S.
Thanks, Dr. Barabel and Sarah. We'd like to now open it up for questions. If anyone has any, please press *2 to unmute your line, or you may put the question into the chat box on the left-hand side. While we're waiting for questions to come through, could you please take a moment to complete the polls on the screen?
So I put in the polls earlier. I was speaking on mute earlier, so I don't think you guys heard me. But one of the courses that I took early on, and our Center for Practice Transformation took early on, and our quality improvement coaches, we took the IHI Open School course, which goes through leadership, quality improvement, a couple different things. And I would recommend that for state offices of rural health, take that training before you really dive into quality improvement work with RHCs, because it kind of really helps you set the stage, and it hits the fundamental things that Greg talked about today. Just a reminder to press *2 to unmute your line, or you can put questions in the chat box. Give a few more seconds here for these polling questions, and then Cinema is going to pull up one more. We have a question where we'd like to hear back from you on what additional resources you would need in support of this topic going forward. You're good.
For our discussion question, what resources do you need in order to feel more confident moving forward with quality reporting in provider-based rural health clinics? Please press *2 to unmute your line, or the chat box is always open as well.
We're not seeing any questions or comments coming in right now on the chat, but chime in at any time if you have some. Again, just a reminder that if you have any questions as you're going through your competitive grant cycle this year, to let us know, send any questions that you have to the SHIP TA team, and as well we can review your project narrative and your work plan. Just send that over to us if you could by the 28th of November. That'll give us a couple weeks to turn it around to you by the 12th of December, so that if there's any changes you'd like to make before you submit it on January 3rd, that gives you at least a couple weeks over that holiday time to get that finished.